overcome this. We have to face a lot of challenge, and today I think all of us, despite trying our level best, we have failed to match up to the expectation of technology. My apologies to all the participants who were interested to doing it. Our assurance is we will come back to this topic again with a wider audience. But as of now, we are live on Facebook. You can inform your colleagues, friends, whoever is interested in watching this webinar. Let me now not waste a further time, introduce you to our first speaker, Dr. Arun Maiya, who is a professor and dean, professor of physiotherapy and dean of Manipal College of Health Professionals in Manipal University at Manipal. Dr. Maiya has more than 25 years of experience in physiotherapy with his highest degree as PhD. Over to you, Dr. Maiya, now for taking us through this addressing functional limitation and O2 saturation in building exercise capacity following COVID-19. Thank you, sir.
Yeah. Thank you. Good evening, Dr. Nitesh and all the viewers. On behalf of the Society of Indian Physiotherapists, it gives me an immense pleasure to interact with you all through the webinar. Addressing the functional limitations and oxygen saturation in building exercise capacity following COVID-19. The outline of my presentation is COVID-19 clinical manifestation, desaturation and functional limitations in COVID-19, the assessment of desaturation and functional limitations, what are the important points we need to consider from the rehabilitation perspective. If you look at the COVID-19, the entry of SARS coronavirus is started in 2019. Initially, it was called as COVID-19 or the coronavirus disease 19. And looking at the clinical manifestation, the reference name for the coronavirus is now severe acute respiratory syndrome. And also we call it as SARS coronavirus 2. Then the name corona is basically a Latin word. It means crown or the wreath. It's a group of RNA virus cause the disease in mammals and the birds. In human, it starts with the simple respiratory infection that's starting with the cold. Then it can extend up, or the severity can reach up to the pneumonia or the acute respiratory distress syndrome. It's highly contagious, and human to human transmission occurs approximately within 2 to 10 days. If you look at the diagram, the spike that adorn the outer surface of the virus, which impart the look of a corona surrounding the viron. This is basically a report of the Center for Disease Control 2020 based on the electron microscopically. Why it is important is the entry of the SARS, the coronavirus, into the cell is initiated by a glycoprotein. A glycoprotein is binded with that spike, and then it is entering to the body. Why this is important is in elderly populations or people with having comorbidities like diabetes or the cardiovascular disease, they are prone for binding this glycoprotein so that the severity can become more in this population. Therefore, the social distancing, the personal protective equipment, as well as the regular hand hygiene is an important preventive measure for the coronavirus. If you look at the summary of the coronavirus or the COVID-19, the disease progression starts from the fever, non-productive cough, vomiting, nausea, diarrhea, or in the certain percentage of the people, it may be asymptomatic also. The second week onwards, if the disease progress, it becomes more dyspneic, shortness of breath, chest tightness, and some percent of the patient, depends upon their comorbidity and the age, they may require an intensive care admission. Sometimes they may require the mechanical ventilatory support, intubations with advanced life support. The organ failure, the majority of the patients will develop a hypoxemic respiratory failure. According to the studies, more than 90% of the people develops the hypoxemic respiratory failure, septic shock about 30%, acute kidney disease about 30%. This is important because when we look at the investigation, especially the arterial blood gas analysis, patients may manifest with the mild to moderate or even severe metabolic acidosis, or sometimes with the mixed picture of metabolic with the respiratory acidosis, there will be a severe base deficit, high anion gap, and lymphopenia is a prone for developing more infection. The common elevated creatine kinase, which indicates the severity of the muscle damage, especially the skeletal muscles and the cardiac muscle. And the another important factor is the increase in the C-reactive protein. The C-reactive protein is important because when there is an elevated C-reactive protein, which usually leads to a right ventricular dysfunction, and it's also one of the predictor for the prognosis of the pulmonary embolism in COVID patients. If you look at the X-ray, there are the radiological findings. Maybe the patients may develop the pneumonia. If you look at the non-homogeneous opacity with the air bronchograph, and also there is a patchy infiltrations. If you look at the other X-ray, there is a clinical or the radiological manifestation of acute respiratory distress syndrome. There is a bilateral infiltration with pulmonary edema, as well as there is an obliteration of the costophrenic or the cardiophrenic angle. The most important changes because in the COVID-19 is there is an oxygen impairment. As we mentioned, it is a respiratory disease, so that there is a compromised oxygenations to the people. So the severity needs to be stratified, whether they have a mild, moderate, or the severe ARDS. The mild ARDS, usually the PaO2 by FiO2, if you look at, the PaO2 is less than 200 millimeter of mercury, or the FiO2 less than 300 millimeter of mercury, with the PEEP on more than 5 centimeter of water, or sometimes non-intubated. Whereas the moderate and the severe, severe is basically a PaO2 by FiO2 is less than 100 millimeter of mercury with the PEEP more than 5 centimeter in non-ventilated patient. Generally, we classify or define the ARDS when a PaO2 by FiO2 ratio is less than 200 millimeter of mercury. However, since considering the oxygen impairment in the COVID, it is important for us to stratify them mild, moderate, and the severe ARDS. Normally, this indicates the prognosis. In case in non-ventilated patients, when the PaO2 is not available, we can take the saturation or the SpO2 by FiO2. If it is less than 315, suggests the acute respiratory distress syndrome. The question number 1 to the viewers: what is the mechanism of hypoxemia? Is it the ventilation perfusion mismatch, intrapulmonary shunting, diffusion impairment, or all of the above? Your time starts now.
Dr. Maiya, I'm sorry, we will not be able to run it as a poll.
Okay.
Meeting
Yeah.
But
Okay.
shall I? Yeah. People can think about the answer themselves, and you can declare it later.
Yeah. Late. Okay. Okay. Then, most important thing is the hypoxemia in COVID-19 patient. The most common mechanisms in COVID-19 is all the 4. There is a ventilation perfusion mismatch. There is an altered perfusion. This is very, very important from the point of pulmonary embolism. Even the recent studies have highlighted that the COVID patients are prone for developing both respiratory as well as the pulmonary embolism is one of the cause for increase in the mortality. Whereas in the altered ventilations, usually manifested with the pneumonia or the acute respiratory distress syndrome. Then the next important point is the intrapulmonary shunting or the right to left shunting. Because the lung is filled with the fluid, there is no chance for the gaseous exchange in the lung. Therefore, there is a right to left shunt. Then the next important point is the diffusion impairment. The diffusion impairment is usually compromised because of the, once again, the interstitial space is loaded with the fluid or the fibrotic changes. And the last point is the lower partial pressure of oxygen. And another important point here is the recent studies have also highlighted that depends upon the ventilatory duration as well as the dependency on the mechanical ventilator, the patients are prone for developing the ICU acquired weakness is an important clinic assessment we need to do from the rehabilitation's point of view. In clinically, we usually define the hypoxemia as if the saturation is less than 90%, then usually we say that there is a chance for hypoxemia. And in COVID patients, it's important for us to maintain between 93 to 96% of SpO2. If the patient develops a ICU acquired weakness, these 2 points are very, very important because there are microvascular alterations and the bioenergetic failure. When we say the microvascular alteration, there is an increased expression of the E-selectin. When you say the E-selectin, when there is a sepsis or when there is an uncontrolled diabetes or the elevated glucose level, there is a chance for an increase in the microvascular permeability. This microvascular permeability increases the edema. These 2 are responsible for an persistent refractory hypoxia failure. The most important aspect is the reactive oxygen species gets increases and the mitochondrial dysfunction. These 2 are important points for the oxidative damage. Therefore, the patients are prone for developing the critical illness polyneuromyopathy. The assessment and the management, I will be highlighting quickly on the assessment component. To start an early initiation of the exercise, and the exercise is very, very important for reversing the hypoxemia and the functional limitation, and it's also important for improving the exercise or the aerobic capacity. Therefore, a thorough assessment is important before we start any rehabilitation approach. First important thing we need to do in COVID is evaluation of the exercise intolerance. As you mentioned, the hypoxemia or the refractory hypoxemia is one of the important clinical manifestations in the COVID-19 patient. Therefore, assessment of the breathlessness needs to be continuously assessed using the pulse oximeter and handheld pulse oximeter. And the most important thing, then unpublished data also highlighted that a deteriorations on exertion, even a simple walk or the stand, and if the desaturation happens or if falls less than 3%, then it is one of the indicators for the poor outcome. Therefore, in these patients, we important to assess the exertional desaturation, and accordingly we have to start our rehabilitation measure. This is the first point to assess. Once the patient is off the ventilator or shifted from the ICU, we can quickly look for the mobility assessment for readiness. There are various parameters, PaO2 by FiO2, or you can also SpO2 by FiO2 can be calculated, PEEP, saturation, respiratory rate, heart rate, mean arterial blood pressure. This is important to assess the tissue, usually tissue ischemia or the hypoxemia. Then the systolic blood pressures, and also another one is important is the Richmond agitation severity scale, basically to understand whether the patient will be cooperating for the rehabilitation aspect. And if the patient is developed an ICU acquired weakness, it is important for us to assess that before we start any exercise test or the functional exercise testing. You can clinically quickly assess for the weakness developing after the onset of the clinical weakness. Look for all the major group of muscle. Commonly, we use the medical research council's sum score, and increase in the mechanical ventilations, these patients are prone for developing the ICU acquired weakness. So one simple assessment all of us clinically can do is take the three important muscles of the upper limb, 3 important muscles of the lower limb, assess their strength quickly, so that you will have a 12 muscles on either side, right and the left. The score 0 to 5 is 0 is completely paralysis, 5 is normal. And if the patient is having a normal muscle strength, then the score is 60. And if the score drops less than 48, that's one of the common clinical indications for ICU acquired weakness. This point is very, very important because even in the COVID, normally we go for various tests, and the strength of the muscle is important contributing factors for the outcome of these tests. I will not go into the details of these tests because the next speaker, Professor Savita Ravindra, will highlight a bit about that. However, 1 minute sit to stand test as well as the 40-step test. These are the 2 important initial tests can be done in the recovering patient, basically to understand with this simple activity whether there is any disappropriate or the disproportionate increase in the tachycardia or the heart rate, and also there is a potential desaturation. If the patient is responding good, then we can go for the other test to assess the timed up and go test, basically to assess the balance, mobility, and the fall risk of the patient. And most commonly, we look for the functional capacity we assess through the 6 minutes walk test. Fatigue assessment scales can be used as a pre and then the post assessment or the rehabilitation aspect also, because fatigue assessment scale is a 10-item scale which usually helps in assessing or reporting the symptoms of the fatigue, how exactly the patient is feeling even after the test or the rehabilitation. The question number 2 for the viewers is, what is the definition of severe acute respiratory distress syndrome? Is it a PaO2 by FiO2 less than 100 millimeter of mercury with PEEP more than 5 centimeter of water or non-ventilated? 100 millimeter of mercury of less than PaO2 or less than 200 millimeter mercury of FiO2 with PEEP more than 5 centimeter of water or the non-ventilated? Saturation less than 88% or PEEP more than 30 centimeter of water? So think about the answer. In summary, in coronavirus disease patients or in the SARS patient, hypoxemia due to the lung pathology and the pulmonary embolism is the most common respiratory manifestation. Therefore, there is a need for early assessment of desaturation. The functional assessment is important for the early rehabilitations of the patients with COVID-19. Thank you all.
Thank you. Thank you, Dr. Maiya, for such an elaborate and detailed presentation about it. Unfortunately, we couldn't deliver the way we had planned it with the poll, where we can take audience opinion as well. But anyways, we did something, and I promise that we will come back to our audience for the way we have planned it. We have few questions which are generated through audience, sir. I'm sure we'll come back to you on this towards the end of the session and ask you. Meantime, can I request you if you can stop sharing your screen?
Yes, okay.
I will.
Thanks.
Thank you, sir. We'll come back to you again, sir, now.
Thanks a lot. Thanks a lot, Dr. Nitesh.
Yes. Now it's a time to introduce. I think we still have some challenges. We are not able to overcome those challenges. Let me see if we can try and do something. Savita ma'am, can you hear us?
Yes, I can.
Can you try and one more switch on your camera in case if it works? I've tried to make you the co-host.
I've tried.
It doesn't work. Anyways, leave it, ma'am. Let me introduce to all of you Dr. Savita Ravindra, a name which doesn't need an introduction in the field of physiotherapy. She is working currently as a professor and head of physiotherapy in MS Ramaiah Medical College at Bangalore. She has been in the numerous committee of Indian Association of Physiotherapists, currently also serving our executive president at Society of Indian Physiotherapists. She has been chair of Asia West Pacific region of WCPT for 2 years and as a member for 1 term. So with these words, let me put you to Dr. Savita Ravindran, and our apology, you will not be able to see her, but we will be able to what she wants to say.
Can you see my screen?
Ma'am, let me try if I can share your presentation because I have one copy with me.
I've started to share my screen, but I think...
Ma'am, I can't see. Let me see if I can open up your presentation, which I have with me, in case that helps. Give me a sec, ma'am. I'm trying to locate that and put it on your screen.
He's not able to share.
You can at least see your presentation.
He can. He's trying to put my presentation because he can't see my presentation. So all this won't come.
Ma'am, it's getting a little difficult. Ma'am, can I request, can you see my screen now?
No, I can't. I'm fine. I can do it from my presentation while I'm watching it on Facebook simultaneously.
And there is a lag on Facebook. It will not be.
I can't see it from your. I can't see your screen.
But you can you can see me there, but not the screen.
Exactly. Nitesh, please go on. I'll follow.
I hope it works now. How about it now?
No.
I think audience can see now. Just let me confirm.
There's a delay, Nitesh, on the Facebook.
Ma'am, we have the screen now. People can see your PPT. Kindly go ahead.
It's not coming on.
Ma'am, I have the title slide on the screen, which people can see. I have moved on to your second slide, which is your objectives.
Hello.
It's not coming on the Facebook, Nitesh.
It will be slightly
ನಾನು ಮೀಟಿಂಗ್ ಅಲ್ಲಿ ಇದ್ದೆ ಮತ್ತೆ ಮಾಡಿ ಮತ್ತೆ ಮಾಡಿ.
I can't see the screen, Nitesh.
Anyways, go. Let's do that, ma'am. I think we can't help. See, they have failed us again.
Yeah, I think my screen, my title has come on. I'm going to speak from what I'm seeing on the Facebook. So good evening, everybody. With all the best intentions, we end up having technical glitches, and my part of the talk is really going to be looking at what can you do in your clinics tomorrow morning. What can you do at your clinics tomorrow morning if you had to start your clinics and we get into a situation where we start receiving post-COVID patients? Fortunately, at the point in time in India, we are not seeing the criticality that you see in North America and Europe. None of our patients in volumes are in ICUs. Most of our patients are in isolation wards, and therefore, our jobs are probably going to be a wee bit easier. Some of the objectives of my presentation are to look at the implications of clinical practice, to look at a few tests that you can do very quickly in your clinic, and a couple of two small things that I would like to tell you as practice strategies and what could be a possible take-home message for you. So when I'm linking the clinical implications of trying to understand the issues with COVID, as I said just before this, that we are not able to have so many patient population that may really come to rehab. Most of the information we have is going to be very anecdotal. However, evidence is being updated very quickly from the Western world and what can be post-COVID limitations. So straight away, trying to put across what I want to share with you, I'm saying that it's time you start integrating practice. What I mean to say is people in clinical orthopedic practice cannot ignore terminologies that Dr. Maiya said called fatigue, endurance, and the likes. Clinical practice in the last couple of years has gone into very many verticals. This needs to be merged and you will need to treat patients as a whole. One of the things that at the outset I want to say and reach out to all of you in clinical practice is two very critical things. Number one, you must have an infrared thermometer, as I said, because that's a standard thing that everybody uses in practice. But as a physical therapist, more importantly than that, please go out and buy yourself a pulse oximeter. Your patients are not going to be the same as a pre-COVID era. It will give you two parameters, saturation of oxygen and as well as a pulse rate. Number two, for those of you who use minimalistic documentation, it's not likely to work as well. For me, there is no conflict of interest when I put up something of an app which is very easily available on Play Store. It's called the Therapeutic app, which I came across while doing an interactive session with APTA, the American Physical Therapy Association cardiorespiratory section. Believe me, this app is available. It's only 400 rupees for what it gives you, for what it does it download, and for the ease of your clinical practice. 4 things that you are going to see in the post-COVID era in your patients. Number 1 is fatigue. Fatigue will be coming because of a disease process. It can also come because all of us are at the moment very inactive. Number 2, something that you have never seen before is what you're going to see, strength coming from sarcopenia. What do I mean by sarcopenia? Is patients presenting with muscle loss. You may have muscle weakness, but muscle loss, like you will see in the elderly, you will start seeing in all age groups. Number 3, you will see a huge drop in endurance. You can have a simple patient of OA knee who just will not progress because you did not measure endurance. Understand this is a post-COVID era. And the last one, you will see people with reduced functional mobility, as Dr. Maiya said. So the first thing, I can tell you what we do in our practice even before COVID started. For all of our inpatients who are admitted, who spend some time or long time with us, we use fatigue scales. There are multiple fatigue scales in the market. The one that we use is what I'm showing you. It's like a visual analog scale. It's called the fatigue numeric rating scale. You can see one of my colleagues in the wards, and it's a standard practice for us. In India, one other thing for all of you to keep in mind is people do not understand the meaning of the word fatigue. In India, culturally, we understand how tired are you. There is a small difference between fatigue and tired, but you could use the word tired. The reason being, a person who's very tired, if they sleep a good sleep at night, most often they feel better the next morning. In case of fatigue, this is not true. They get up in the morning, feel they haven't slept enough, which must tell you that fatigue is a disease-driven sense of tiredness, and therefore will be seen in post-COVID patient, and you must incorporate a simple tool of your choice. The second thing that we have started using in our practice is strength measurements. I can share with you just 1 or 2 simple things that you can do that does not take away too much of your time. Why are we losing strength post-COVID? Because of the inflammatory process that happens during COVID. There is lack of oxygen, as Dr. Maiya said, to the muscle tissue. At this point, I want to just reinforce that we have no idea that oxygen saturation will become such an important thing in our practice. Very recently, when I was listening to a talk by Dr. Sanjay Oak, who's on the task force at Maharashtra, one of the things he said that they have started to use extensively now in screening pulse oximeters to screen people. And then he went on to say that during the screening at Dharavi slums, out of the 1 lakh people screened, and all of them, most of them being asymptomatic, 619 people presented the first sign in drop of oxygen saturation. So if you are asymptomatic and you present with this, post-COVID and inactivity patients will present without measuring oxygen saturation. If you go back to your clinical practice, you are asking for a patient to collapse in your clinic. So be very clear that while measuring strength, oxygen saturation should be measured. At practice, you can do 2 simple things. That one is called the grip strength. Grip strength is very easy. And I've just put up a female score on grip strength that is Indian standards. And I'll tell you why. This is the grip strength that I'm showing you of a 75-year-old lady who, this was the start. And at the end, she showed 13 kilos in grip strength. The normative value for 70 to 75 years of age is 11, which means grip strength is a measure of gross value. So it looks like she's not completely depleted, but we will need to look further if we want to understand why. The second thing I would like to measure of this lady would be endurance, because endurance is completely changed pre-COVID era. What can I do in my clinical practice that I can do quick and fast? The 1 minute sit to stand, as Dr. Maiya said, of flat 40 flat steps. What do I prefer? I prefer the 1 minute sit to stand, unless I have a person over the age of 80 who's coming to my clinic. So how would I do that? Again, it's my same lady who's 75 years. Before I started doing the test for her, her SpO2 on the pulse oximeter was 97, which was a good level. Her respiratory rate, heart rate was 79. And then I'll tell you what happened. So I just give her the instructions and I ask her that she will do a 1 minute sit to stand at the start of the word go. And when she finishes her 1 minute sit to stand, I will re-look at her oxygen saturation and the heart rate. What I have observed, that at the end of 1 minute sit to stand, her saturation dropped to 95, which means by 2%, and her heart rate increased in just 1 minute to 89. The number of repetitions she did was a total of 9. I will come back to this point after 2 slides. The last outcome measure that I say in clinical practice, again, you need to do it for the first time the patient comes to the clinic, is functional mobility. Why is it important? Dr. Maiya pointed out you could use anything that you are comfortable with. You could use tug scores, you could use work balance, you could use gait speed. What I have used, or what we tend to use now, is the L test for functional mobility. Why do I use this? Because it is a step above the tug. In evidence and in research, what L test functional mobility does, it destroys or crosses over the ceiling effect that you will see while doing tug. Again, it is the same lady who's 75 years of age, and she took 21 minutes to complete the L test. The L test is a 10-meter test. Why is it called L? You walk 3 meters in one direction. You take a left turn and walk 7 meters. And I will speak a couple of seconds after you have a video, after you watch this video.
Ma'am, I'm trying to play this video, so let's hope it works here.
Yeah, that's fine. So the lady will walk 3 meters in one direction, and then she will go down the length of the 7 meters. She turns around, comes back, and then she will sit down back in the chair. So she took a total of 21 seconds to complete this test. The normative value for people for 70 to 79 years is within 27 minutes. So she was good to go for that too. So here's what I am saying to you.
Ma'am, I'm sorry, I think there is some issue with the video. Let me try once you end your presentation.
No problem. You can move to the next slide.
Ma'am, I'm on the interconnected slide.
So there are 3 things that are interconnected in post-COVID mobile patients, whether it's an orthopedic case, whether it's an adult, whether it's a pediatric, be very careful, or if it is a neurological deficit patient. Mobility, endurance, strength go together. Most often in orthopedic practice and in neurology, people do work a lot with mobility and strength, but this time you'll have to put the nick in for the endurance. A small word of caution: when you are exercising your patient, if you see the heart rate dropping, one of the complications that COVID-19 is coming out with, according to present literature available, is the person may have developed cardiomyopathy as an outcome of COVID. If you see from resting heart rate or while exercising, instead of heart rate going up, if it starts dropping, pause. Don't continue the exercise. Be careful. So here's the outcomes of my example. I had a lady who was 75 years. Her grip strength was 13. For her age, normal is 11. So her grip strength or generally strength was okay. Her functional mobility took 21 seconds. For her age, she should do it within 27 seconds. Even that was good to go. Now, here's where I found the problem. She did 9 repetitions of a sit to stand in 1 minute, which you can very easily do in your practice. Normative for her age is around 18. One more point of concern. For just doing 1 minute of sit to stand, her SpO2 dropped from 97 to 95. It dropped by 2%. Anything that drops by 3%, you have a crisis in your hand. Therefore, I cannot reinforce the need to do such oxygen saturation in your patients. As an individual like me, because I found her endurance affected, because I thought her strength was reasonably okay, in my clinical practice, I would wonder, where is this coming from? Post-COVID patients are known to lose muscle strength in your core muscles. Orthopedic practitioners, be very careful when you are doing extensive core stability exercises. And therefore, diaphragm works in conjunction with the core muscles. I would try to do an inspiratory muscle strength. You may not have the instrument of this kind. You can use a simple spirometer, but you will get a volume value, and that would be able to start your benchmark of thinking, I need to retrain her inspiratory muscle strength. What are treatment strategies? As my next speaker will also say with you, there is no cookie cutter menu for all. COVID patients are presenting with accessory muscle overuse, never having a respiratory problem before. They are presenting with hemiparesis. We have heard and seen patients getting Bell's palsy in the middle of summer and other seasons, as many more numbers. They are also seeing people with neuropathy. So there are really no cookie cutter menu, that one thing that works for all. But the one thing that works for all is their endurance in all of them come down. Therefore, whatever be your line of practice in your patient, please start with some endurance exercise, like an example of low intensity. They do an exercise for 2 minutes, they take a rest of 1 minute, and they may do it for 8 to 10 steps. When you start strength exercises, and just 2 days back, we were talking to somebody who works in muscle biology from the US. He was very clear in saying to us, don't start weight bearing exercise. Don't tell your patient, start walking, you will be fine. When you lose muscle mass, if you lose 25% of your quadriceps and you advise the patient to go for regular walks at home, they are walking with 75% muscle tissue on the body weight that did not change. Some more tissue will get damaged. Please start strengthening exercises, unloaded position before you step into the loaded position. Start with low weights. If you have older people in your clinic, start in a sitting position, all kinds of exercises that you wish to take for them. And so hopefully I've shared some things that might be useful. Thank you.
Let me try to share the videos, what you have shared with me, with our audience. I hope we will be able to, share some of your thoughts, what you have put it together. I will start with the sit to start video, ma'am, first.
You can if it comes.
Let me try that, ma'am.
He's trying the video.
I think if it comes, it will be very good.
Nitesh, I can put the whole thing up on YouTube as a presentation so that people will be able to view it in the SIP channel.
I'm sure. Can you see anything on the screen?
Yes, we are able to see that.
Yes, I have put the video, ma'am. The video of your sit to stand.
Okay. He's put the video of sit to stand.
We could see the readings, what you shared with us, ma'am. Now I am shifting to your second video, which is about L test. So let me try my luck with that as well.
So you can see the lady doing a sit to stand at the position where she's doing it. Her saturations were 97 to begin, and when she finished, it was 95, and her pulse rate went up by about 10.
Ma'am, now we have the second test on our screen. I just switched it on now.
The L test is what you're going to see now. It's a 10-meter test, and I think it will come on shortly.
It is on, ma'am. Now the lady is coming back.
Yeah, but it's not, okay. It's starting now, Nitesh, on Facebook. So you can see that I'm giving her the instructions, and it will get her to walk through first for 3 meters. And I put a little marker on the floor. So she walks the 3-meter distance. She turns left. She goes down the length of the 7 meters. She turns around like in a tuck test. She comes back. She will turn back and go and sit in her chair. This entire walk, in case of this lady, she did in 21 seconds. And for her age group, the normal range, it should be less than 27. Thank you, Nitesh.
Thank you, ma'am. Thank you so much for sharing your wonderful experience with us. I'm going to come back to you once we are done with our today's presentation. Let me, guys, now introduce you to our next speaker, who is Anubha. She has done her bachelor's and master's in physiotherapy from KLE's JNMC Institute in Belgaum. She has also done her doctorate in physical therapy from Dominican College in the United States. Currently, she is working as a chief operating officer of a company called Kindness Unlimited, a rehab company. She's also a clinical coordinator and rehab services of Little Neck Care Center, New York, United States. She herself, being a COVID patient while treating other COVID patients, she has seen the journey along with the spouse, how the COVID as a disease or as an infection suffers you as an individual, and how as a physiotherapist we can handle patients who are suffering. Over to you, Anubha. Thank you.
Thank you, Nitesh. Good evening, everybody. We apologize for the technical glitch. It's been a great opportunity for me to come here on this platform and share my first-hand, second-hand, third-hand, fourth-hand, all experiences with you all. So to speak about my first-hand experience, I myself caught COVID. I work in a short-term and long-term rehab center. I work in outpatient clinics as a supervisor. So I was all over the place. And I'm sitting live here in New York, the biggest epicenter of COVID-19 at the moment. Our numbers have even surpassed China's number. So as of yesterday morning, we had about 348,000 confirmed cases of COVID-19 in New York. And we reported about 22,478 deaths. Now, when I got COVID, I, like everybody else, going to work every morning was stressful, anxiety provoking. But when you're a healthcare worker, there's no other way out. You have to go to work. This is the time. So I started my symptoms with malaise, with body aches, nothing classic. I never had fever throughout my journey. By the third day or fourth day, I lost my sense of smell completely. Everything smelled like cardboard to me. So that's when it rang a bell in my head, because by that time they were talking about this being one of the subtle symptoms, and I had it. So I decided to get tested, and I tested positive. And following the CDC guidelines and DOH guidelines, I isolated myself at home. Fortunately, I recovered at home. So I can be considered, I can call myself a milder case. I recovered completely within 14 days, actually less than that. I would say by 10th or 11th day, I was up and about, going about my business, doing house chores. So that was my first-hand experience. No respiratory symptoms, loss of smell, a lot of weakness. Like Savita ma'am said, endurance issues, which I still have, I'll talk about that later. My second-hand experience. So I come home from work feeling sick, and I see my spouse sick. He was almost semi-conscious. He had a fever of 103. And he said, I can't get myself to get out of bed. Boom. We both get tested at the same time. We both test positive at the same time. Now, coming back to his experience, obviously I was going out to work. He was staying home. I brought it home and I passed it on to him. Same strain of the virus, but he presented so differently than me. He was suffering way more than me. His fevers persisted for about 10 days. He had upper respiratory congestion. He had cough. By 9th and 10th day, while I'm almost recovered, he started showing more chest tightness symptoms. We did not have a pulse ox at home at that time because we were never expecting to get it. Like ma'am said, prepare yourself, have it. Now it's available and everybody can have it. At that time, if you order something at that time, you wouldn't get it. So we were kind of concerned at that time that he might end up in the hospital. But right there and then, all the memories from the chest physical therapy class came back to me. So talking to all the healthcare professionals, doing telehealth visits with them, and talking to other people in the medical settings, it was advisable that he stays upright. So positioning in his situation, his main complaint was when he tried taking a deep breath with a high fever, that means the virus is attacking his body left, right, and center. As soon as he takes a deep breath, at the end of the deep breath, he would go into a bout of cough. He would go into a spell of cough, which would last about 30 seconds, and he could not even stay up. And after that ended, he was done. He wanted to just lay down. But knowing that positioning can have a very important effect on lung capacities, on clearance of lungs, drainage, and everything, he was instructed to stay upright. I used all my chest physical therapy techniques on him that were relevant at that point of time, and I have to admit, they made a huge difference to his recovery. By that, I mean, I used the active cycle of breathing technique for him, where we breathe normal tidal volume, about 5 cycles. We move on to inhaling, holding for 3 seconds, and completely exhaling, followed by active coughing technique. In his own experience, he's a non-clinician. When I explained that to him and he followed a couple cycles, at the end of that cycle, he would say, I feel much better. I can breathe much better. I feel a little more comfortable. And after that, I would put him in prone position, do a little percussion, and he would stay in that prone position for only 30 minutes. And then the office chair was in the bedroom and he was not allowed to lay down in the bed. So this is what COVID does to the body. In my own experience, seeing patients, seeing my spouse, and seeing all my colleagues, COVID wants you to lay down. COVID wants you to not do anything. But the recovery lies in the fact that you have to come out of that phase. You have to move. So movement by itself has a big, big role to play in recovery. So this was my second head experience. Luckily, we could avoid hospitalization at that point of time, and he recovered completely by 21 days, I can say. And we both retested, we tested negative. Now, fast forward 6 weeks post-COVID. Now, I'm 6 weeks post-COVID. He's about 6.5 weeks post-COVID. We still have some residual functional deficits, which I will come back to later. Talking about my third hand experience. I work in a healthcare setting. If I got it, that means many of my colleagues also got it. As you know, you start spreading it before you know, even before you know you're going to get it. So our whole team, one after the other, not only rehab team, physical therapists, occupational therapists, speech therapists, but all the other teams, our nursing teams, our CNAs, our physician assistant, nursing practitioner, we saw them dropping like flies within that week. So we definitely had it in the facility and we passed it on to each other. Out of that, I'm still not able to draw a conclusion. What is the pattern to this COVID-19? The whole world is struggling with that. I saw such different presentations with my colleagues, young people. I saw patients from the age of 32 up to 103 years old. The spectrum is so wide and the presentations, clinical presentation is so variable and the recovery times are very, very different for everybody. I see some of my colleagues recovered back to work, but I can't have a conversation with them for more than 10 seconds. After that, for example, one of the nurses, we're having a conversation and after 10 seconds, she has to stop talking, take a deep pause, and then start back again. And as a PT, my eyes go to those accessory muscles. You see her sternocleidomastoids, her scalenes popping, and the deep pause. And after that, they stop. So residual respiratory impairments. Another colleague of mine, a social worker, recovered completely, an athlete. Prior level of function, she is also a physical trainer on the side. Came back happily, 12 days later, I'm out of it, comes to us saying, I have this isolated muscle ache in my both quadriceps. Thanks to Savita ma'am for highlighting that. This COVID is doing a number on people's systems very, very differently. So when we see patients in all these settings, I was going to do a poll, and unfortunately we can't do it. I was going to ask how many people have a direct or indirect experience with a COVID patient. In India, I understand we are not seeing many. Let's keep it that way. That's very fortunate. Unfortunately, we see a lot of patients post-COVID in the form of colleagues, in the form of neighbors, friends, in the form of hospitalized, recovered patients that come to rehab centers. Now, since the spectrum is so wide, we categorize them into two categories. The ones with respiratory involvement, the ones without respiratory involvement. The ones with respiratory involvement, they go home. Again, there are two categories on that. Some are on oxygen support at home via nasal cannula. Some are not with that, like my colleague who is short of breath, who is impaired lung capacity. Even basic talking makes her short of breath, makes her go into hypoxia. Now, as a PT, if you come across down the line a patient with respiratory involvement, there are a few very key things. Dr. Ravindra already talked about what to keep in mind, the pre-exercise O2 saturation monitor, the post-exercise monitoring, and the assessments. Thank you for that valuable information. All that is practical, and we do that in our day-to-day practice. Assessments have to be done to keep a track of progress. Some things that I noticed, anybody who is on more than 6 liters of oxygen, it is important for the therapist to have the right PPE. Any aerosolizing procedures that you have to do with a patient who has respiratory involvement, you have to have the right PPE, because the COVID virus can shed even post-recovery, like they say. We don't know. Or the other scenario can be, you can be an asymptomatic carrier to that patient. So the golden rule that we follow here is, obviously mass testing everybody is not going to be possible. So you go in with an idea that everybody around you is an asymptomatic carrier who has the capability of infecting others, and you yourself are an asymptomatic carrier who has a capability of infecting somebody else. So let's not get infected, and let's not infect others. Keeping that in mind, these aerosolizing procedures, simple procedures that PTs do all the time, like nebulizer. Nebulizer creates aerosols. Aerosols can transmit from patient's breath into the environment. From the environment can go into the patient's breath. So to avoid that exchange, simple procedures, use your masks. A simple surgical mask, probably not enough for aerosolizing procedures. You have to have an N95 mask, or at least double the layer up. That's what we have been advised, and we follow it. So providing chest physical therapy in 2 units, even with regular patient, COVID, non-COVID, let's get these into our practices. This will become a new norm. Unfortunately, we have to adapt and change our practices. So this was about the respiratory, and all the golden rules of chest physical therapy still stand good. We follow the same principle of chest physical therapy exercise: keep the lungs clear, strengthen inspiratory, expiratory muscles, positioning, localized lobe expansion exercises, your postural drainage. We are using all of them in our respiratory COVID patients for recovery, and we are seeing great results with traditional practices. Based on your assessment, design your protocol on the same universal principles of exercise: your mood, intensity, frequency, and duration. Now, coming on to patients who are either asymptomatic or they don't have respiratory involvement, they are mild cases like me. So from my personal experience, is my exercise capacity O2 saturation that we're talking about today back to normal? My O2 sat never dipped throughout this process, pre-COVID, during COVID, post-COVID. I was never short of breath. But the element that was emphasized, my endurance is not the same. Pre-COVID, I was able to do my cardio exercises, my walking, running, whenever I get a chance, up and down the stairs, 30 minutes, 3 times a week. And 2 times a week, I would do body weight strength training, my push-ups, my dips, my, not there yet with pull-ups, but weight training with free weights, body weight squats, and all that. Ask me today, 6 weeks post-COVID, my personal experience, I would say my exercise capacity has reduced to 50%. Even if I spend time on it, I feel tired. So my rate of perceived exertion is the scale I'm commonly using on myself, with my husband, and with the patient. Very simple. The tests are great. They are very objective, but the first assessment goes with subjective assessment. And patients come and say constantly, during rehab, pre-rehab, post-rehab, I'm tired, I can't do this. So the question we ask, what are you not able to do today that you were able to do pre-COVID? Even patients who have never had COVID, but we are seeing them in our centers, they themselves, because of this immobility at home, sitting at home, people are deconditioned overall. So our first question to them is, what were you able to do pre-COVID that you're not able to do now? Some of them say, I have been able to continue, which is very less. Some of them say, we feel a big difference. An average is about 40%, 50% reduced exercise capacity. So with my husband also, he never had, since we didn't have a pulse ox, I monitored his heart rate throughout. So the days with high fever, obviously the heart rate was high. When he felt shortness of breath, tightness, his accessory muscles will also be in usage. So informal assessment, because we didn't have the tools at home. His exercise capacity, he used to do his calisthenics. He is into yoga, he's into meditation, and he would do average 45 to 50 minutes of routine exercises 5 days a week. He is 6.5 weeks post-COVID. Now, since I got the pulse oximeter, his levels are normal now. His O2 sats are normal, but his exercise capacity is down by 60%. His muscle strength also is reduced significantly. He's not able to do his regular exercise routine of squats, his jumping jacks, his planking. He cannot do any of that at the same level as pre-COVID. So we are working on his strength. We are working on his endurance. Now, patients without respiratory involvement, we do an assessment of their functional capacity using standardized testing, with using all the tests that Dr. Maiya and Dr. Ravindra have mentioned, and we design a protocol on our regular principles of mode, intensity, frequency, and duration. And we are seeing great results. The residual impairments, balance, muscle strength, and reduce functional capacity. Say, for example, 75-year-old male recovered from COVID completely, tested negative, comes to us. I used to be able to walk everywhere, drive everywhere, do everything on my own, do my groceries. Right now, I can't even walk half a block. So those type of things. So we work on those. Our goals are based on their functional capacity impairments, and we try to meet their prior level of function. And I'm happy to say with physical therapy, with regular occupational therapy, physical therapy, we are able to get them back to the community. So in my opinion, in my experience, physical therapists have a huge role. There's going to be a tsunami of patients after all this is over. Everybody who has experienced COVID or not experienced COVID can use physical therapy intervention. So we have to prepare ourselves as clinicians to be able to look at everybody, keeping that there might be a possible exposure or non-exposure or effect of COVID in their lives. So like it was mentioned, screen everybody for any possible symptom of COVID, any possible residual impairment of COVID, clinical, non-clinical. So it is a good practice to do screening. The other thing that I was asked to touch upon is how many of us feel comfortable going back to work? I worked before I got COVID. As soon as I recovered, I was back at work on 14th day of recovery. because we were short-staffed. Like I said, everybody was dropping like flies. Being a coordinator, I couldn't take off. I had to show up. So going back to work, did I have anxiety? Yes, I did. Was I stressed? Yes, I was. About two things. One, I just recovered from a deadly illness. Am I going to be able to continue with work? The other one was, what if I bring it back home to my family, which all of us will have to do. We'll have to worry about when we get back to work. Currently, I understand, Nitesh, a lot of people have not stepped out. The work hasn't started yet. It's very limited.
Absolutely. But I think now we're planning, the India government is planning now, and a lot of healthcare people have started working from this week. The week just got over, and coming back, I think now it's going to be open, especially for the healthcare.
Right, so the anxiety is real. The stress is real. We can't underplay that. I will not try to tell you, no, it's okay, it's not what they're showing. No, it is real. So how we handle it, this is, again, no scientific present. This is my own personal experience. I have turned my anxiety into level of confidence, level of comfort, where I don't feel stress going to work. And how I did that? By educating myself, by being aware. Educating myself, there is enough and more information how the virus spreads, how we can cure it, how we can prevent it. All the WhatsApp messages we get every single day. So we have enough and more knowledge, but practically what we do. There are two aspects to this. As a clinician, I have to feel comfortable going to work, coming back to my family and living a normal life. It's hard, but I have to find out some strategy to be able to do that. The other aspect is your patient has to feel comfortable coming to you, because everybody knows there's this deadly disease out there. Even if you start working, are your patients comfortable working with you? Because they see you as a potential carrier. They see your clinic, your gym, your workspace as a potential source of infection. So what are the practices we are using currently? So when we go to work in the morning, everybody is screened. Every single person that walks into the facility, we are informed that the worst is over, but as a healthcare worker, we are told to still be on edge with this. So we all are screened. Our temperatures are taken every morning. We have to answer a questionnaire every morning at the front desk of every facility. Have you been in contact with somebody? Have you lived in a community where there is a widespread? Are you in a secondhand contact? Anybody in your family has it? All those, the regular questionnaire. So we answer that, temperature taken. We put on our masks. Mask is a mandatory PPE that everybody needs to have at work. We go in, we have to use a hand sanitizer at entry too. Once you go in, you look at your schedule, you start seeing patients, and standard protocols, standard practices of hygiene, disinfection, and PPE. With PPEs, I have to say, they're effective. I have had experience with people who are on the front line. I have a physician assistant colleague of mine who served in a hospital on the COVID for 5 weeks straight. And in the hospital, the policy, the guidelines for PPEs are very, very strict. They do multiple layers of PPEs. After the end of her 5-week shift, she tested negative for COVID. So she said, I don't know how, it must be my PPE that was effective. So she would do double mask, double gown, double gloves, the bunny suit, the whole 9 yards. So coming back to the simple practice, if you see a patient in your clinical practice, any kind of setting, it's best practice for you to have a mask and your patient to have a mask. Post-COVID, non-COVID, recovered, non-recovered, irrespective of anybody's COVID status, a mask is a good idea. Another aspect of the mask is a single layer surgical mask. Is that enough? Some people feel suffocated. So say you're exercising with somebody with a single layer surgical mask, or they should be able to double surgical mask. And the heart rate starts going up, the lungs start getting loaded, they feel breathless. Some of them will take that mask off and say, I can't even breathe in this. So a single layer has its own problem, double layer has its own problem. So now how we tackle this problem? We have minimized our next to the patient time, close contact time. We try to make it about 6 to 8 minutes at a time. We don't go beyond that in one stretch, because they have found out that the viral load goes up with the time spent next to a patient. So for example, if anybody is an asymptomatic carrier, the other one is an asymptomatic carrier, standing next to each other, talking to each other. By the way, talking is also, we limit having a conversation with a patient standing next to them, right next to them, because when you speak, the aerosol that you release also, it is a very, very contagious way to spread the virus. Symptomatic, asymptomatic, doesn't matter. So we try to minimize our conversation with the patient when we are standing next to them. All the discussions, all the conversation can happen keeping a good distance, at least 3 feet to 6 feet. Conversations don't have to be next to each other. So that's one. Everybody has to have a mask. Anxiety is not only in you, also the patient. So educating our patients on our practices have improved the level of comfort that we see in our practice. So when we spray the couches, when we spray all the instrument, when we disinfect, we inform them, this is for your protection. This is for my protection. So although we assume everybody knows it, but saying it and acknowledging it and validating it at that point of time has found to improve the level of comfort that the patient has with you. So we educate not only ourselves, we also educate patients. Changing your PPEs, please follow the guidelines for the sequence of donning, doffing, and disposal of PPE. PPE not disposed properly has found to increase the spread of it. So what goes on first? Never ever touch the outside of your mask. Don't wear gloves and touch everything. Standard protocol. Sometimes, because this is new to all of us, we forget, but it's a good reminder. Remind your own self. We remind each other. You forgot to take your gloves off, or you didn't wipe that instrument. We don't hesitate to bring it to anybody's attention. So in a clinical practice, it's a good idea to remind each other. When you work in a team, we sit next to each other. We used to sit next to each other. So in order for us to protect ourselves and our colleagues and the staff members, we have created stations that are 6 feet apart. We don't sit next to each other anymore. We used to sit together during lunchtime or hang out. All that is done, but with social distance. We try to stay apart at least 3 feet. When we're eating together, we don't talk much. Like I said, the spread is high with the aerosols generated during talking. So it's easier for me to say now that I've experienced it. Don't get anxious over it. That brings your immunity down. Don't get stressed over it. You're compromising your own immune system with that. We know that anxiety and stress can bring your immunity down and make you more prone to get it. Coming home from work is also anxiety provoking. What did I touch? What am I taking home with me? Where did I put my bag? I go to my workplace with nothing in my hands. I try to not use my phone, minimal accessories, no rings, no watches, no, I don't wear my hair down anymore. I try to avoid as much as contact as possible. When I come back home, I leave my shoes outside, straight away walk to the shower, all the clothes that I have on, go to the laundry right away. And on top of everything, I work on my immunity still. Prevention is the first step. Your own immunity is the only thing in your hand, only guarantee that you can have. It has been found time and again. I notice it in people that I see recovered. Their baseline status of health, their baseline status of fitness has helped them to recover. And those are the patients who were not intubated. Recovery-wise, if you see patients who have recovered, have residual impairments, we need to work on that. I have even gone to an extent to explain to somebody, let's work on your endurance, let's work on your respiratory muscle, let's work on your overall fitness, change your routine, change your diet, change your everyday practices. So God forbid we have another pandemic, which I wish never ever happened, you're not the one who will be intubated. So this is my learning from COVID. I will be happy to answer questions. And it's been a journey. Thank you so much, Nitesh.
Thank you so much for sharing your experience. Let me invite my other guest speakers as well. I pray that Savita ma'am also can join us and we can see her. Can I request each one of you to kindly switch on? Yeah, we have Dr. Maiya. Savita ma'am, is it possible or still a challenge?
I can see all of you because I can see you all on the screen. Somehow you guys can't see me. I've started my video. I've started it, Nitesh.
Fine, I understand. I think we are still at the same problem. So let me start up with a quick round of questions. Dr. Maiya, the first question, which is I think for you out of your presentation, it's about what is hypoxia or hypoxemia and why COVID-19 are prone for refractory hypoxemia.
He has to unmute himself, Nitesh.
I will do it for myself. Yes.
Yeah. Good evening to all of you, and it's a very relevant question, Dr. Nitesh. As we mentioned during the presentation, the COVID-19 patient, because of their low immunity, because of their compromised other comorbidities, examples like diabetes or cardiovascular disease or obesity, other associated comorbidity, these patients are prone for developing the respiratory infection, either the pneumonia or later stage, the ARDS. Once they develop that, usually the hypoxemia is a major challenge in them. So here we need to understand hypoxia is usually a low oxygen in the tissue or compromised oxygen in the tissue, whereas hypoxemia is the low oxygen concentrations in the arterial blood. So here patients develops because of this persistent respiratory infection, all the factors which are maintaining the normal oxygen saturation get disturbed. Whether it may be a ventilation, it may be a perfusion, or it may be the ventilation perfusion. As Anubha have rightly mentioned during the positioning, there is a lot of variations can develop in the ventilations to perfusions in our body. Either it may be a sitting, standing, or prone, or the supine position. The ventilations to perfusion is not uniform across the lung zone. So this is the one possible reason. The second important thing is because of the shunting. If they develop a pulmonary edema, or if they're associated with the pneumonia with the consolidation, it will not allow any gas exchange to happen in the lung. Therefore, there is no new oxygen produced in the body. Therefore, whatever the activities or even for the functioning of the vital structure, there is no oxygenation is produced from the body. Therefore, it causes or it leads to the hypoxemia. Therefore, these patients are always requires an artificial or the additional oxygen level either through the oxygen flow system or through the either BiPAP or the CPAP. So this is the possible reason for the developing a hypoxemia in the COVID patient.
And so other one is, following that, why do patients of COVID develop ICU required weakness? So ICU.
Yeah, this is the recent studies also I read. These patients are also prone for developing the ICU acquired weakness. The reason is one is depends upon the ventilatory dependency. If the patients develops a severe ARDS, they may require, it's a very rare, the lower percentage of the people may require ventilatory support. When they are depends upon the ventilatory support, usually it is a challenging for the clinicians to wean from the mechanical ventilator. So you need to extend the mechanical ventilator support, or sometimes even through the non-invasive ventilator support like BiPAP or the CPAP. So when they require a prolonged oxygenation, as Professor Savita Ravindra madam highlighted, there is a sarcopenia, there is a gradual decrease in the muscle mass. So there is no chance for the bone marrow to produce the oxygenation, or the what we call it as the oxyhemoglobin saturation is usually get disturbed in these patients. So the skeletal muscles will go for a gradual weakness. So they may develop the myopathy, or sometimes they may develop neuropathy, or most of the patients develops critical illness myoneuropathy. That's the reason both the speakers have highlighted about the muscle inhibition, the pain, all these actually and warning signs for these critical myopathy changes.
Thank you so much. Savita ma'am, the next question is directly to you, where somebody is asking, can you share some practical tips for a pediatric clinic specifically?
You know, that's one of the hardest areas of practice to start off to begin with, because the amount of contact that you will be required to do in a pediatric practice is very high in terms of your contact hours. But a lot of things that have been said by Anubha is things that you will have to practice in terms of your guidelines on screening, in terms of your on contact and off contact. So you will have to divide your practice some of the whatever motor skills that you want the kid to develop, and be in contact for about 6 to 8 minutes, step out for a bit, and let the kid have a rest, and then come back and redo it again. And these are the only ways that you can protect yourself as well as the child. It may look, one other thing that I really want, that Dr. Raju Parashar, when he said, let's talk about O2 saturation and asking functional abilities in people much earlier than what we were looking at, it didn't kind of make sense to me at the outset, but I cannot emphasize beyond more than what I would like to. You can't enter clinical practice without a pulse oximeter. Please don't do it, because as Maiya said, if your peripheral saturation is less or dropping by 3%, arterial saturation is much lower. Therefore, pediatric practice has to do the same guidelines as adult, but you'll have to again do hands-on and hands-off time because of the viral loads.
Right. Anubha, would you like to add something specific to practice or other clinical practice as well? Some practical tips.
Nitesh, clinical practice, physical therapy is going to remain physical therapy, but we have to adapt to new ways. First to treat, but also to keep ourselves and the patients safe in this area of pandemic. The virus is not going away in a day or two. It is here to last for a couple of months. So it will be a great idea for us to develop new strategies in our clinics, in our teaching settings, in our hospitals as physical therapists. I cannot emphasize the use of PPEs more. It protects you and the patients or anybody who's in contact. As comfortable as a mask feels, it is saving lives at this point of time. Minimizing contact time, direct hands-on contact time has helped everybody. Open your windows, go take a breath outside. So frequent breaks while you're working with a patient have helped everybody. And standard practices of hygiene, washing your hands for 20 seconds, not sharing gloves. If you use gloves with one patient, switch them out. Standard practices. Practice of physical therapy have remained the same. Only the clinical practice, the PPEs and all that has been added, super added to our regular clinical practice. Keeping that in mind, we can keep our patients and ourselves safe.
I think last question for today, which has come now, it's about hydroxychloroquine. People have asked specifically in terms of our relation with the United States. It was talked about in India and abroad, across the globe, when President Trump asked the help, and India was very prompt in supplying that. What is the policy of government in US? If you can just share it quickly with us.
Prophylactic hydroxychloroquine has not been used, is not being used. If somebody says, oh, it's being used in India, no. The medical system in America works very differently. It has to have a prescription. You can't procure medicine like that. And it has to be a scientific evidence-based practice. So I haven't seen anybody, including my physician friends, including my nurse practitioners, my colleagues who have access to medication if they want, and even prescribers, they are not being prescribed prophylactic hydroxychloroquine at this point of time.
It's very different from what we hear in India.
Not unlike India. Unlike India, we have been in communication in Indian medical settings, staff has been given prophylactic hydroxychloroquine, not in America, not in US.
Great. Do we have anything to be added, Dr. Maiya and Dr. Savita, on this before we close? Thank you, sir. I think with this, we come to an end of our today's session. Let me share with you the technical glitch what we had with Zoom. It's not only with us. I think the whole world is suffering it. It's all over the news now. We got the updates on online news that there is a problem with Zoom worldwide. That's why people are not able to join. We're not able to conduct. But fortunately, we were able to conduct our session, not the way we had planned. But yes, with the help of all our speakers going extra miles.
Nitesh, there was one query that a lot of people have asked. Can I answer that?
Ma'am, sure, ma'am. Please, if I miss that, please go ahead, ma'am.
Yeah, we all, at the present point in time, at our workplace in Bangalore, Ramaya, we have initiated, like she said, a part of screening. Every morning, there's a daily monitoring for all healthcare workers, including physical therapy department, the PGs and all, where you have to monitor, put in all the standard parameters of screening. But what's been added is every morning we have to give our oxygen saturation level for that day. So the issue that did come up for all of us is, if I have so many people using a simple pulse oximeter, and how do I, what about sanitation guidelines? So the simple answer that came out for it was that the index or the middle finger that you use to put it into the pulse oximeter, sanitize that finger before you put it into the pulse oximeter. So therefore, if everybody sanitizes the finger, and then our infection control repeatedly checked whether the surface had, and that was the one way that we found. We struggled with it in the beginning, and then we came out with this solution. And actually, I must share with you, it was one of our own staff who came out with this idea, and that was Sundar.
Great. I think that's a very wonderful and very informative system, ma'am, that you shared with us. So thank you so much once again, Dr. Maiya, Dr. Savita, Anubha, for joining us today. I know it's very early morning on a Sunday when you have woke up and joined us. Thank you, ma'am. Thank you, Maiya, sir, for struggling with us with this technology. Ultimately, we could talk to our audience, which was 300 plus when we started. I'm sure a lot of people missed out because of Zoom, but we will make it up to them. Thanks so much once again. Before we end, I would like to share the details of our next webinar, which we have planned for next Sunday at 4:30, 24th May, which will be on managing shoulder instability in pediatric and adult hemiplegics. Speaker would be Dr. Asha Chitnis from Mumbai, Dr. Narkesh Armugam from Patiala. Session will be moderated by our treasurer, Kaushal Bhatt. So the link, which is mentioned at the below, you can log into it, register for this webinar. Hopefully, Zoom will be able to rectify its problem and we will be able to connect with maximum people. Thank you so much once again.
Dr. Nitesh, can I just one point shall I add?
Please, sir, please go ahead.
First of all, I think on behalf of all the speakers, I personally thank you for the good coordination, even with these technical issues. Thanks a lot to you for an excellent coordinated webinar.
Thank you, Dr. Maiya. I think it was your support, Savita ma'am's support, Anubha's support, that you changed it so easily, and we were able to connect with our audience. Thank you.
Let's
wait to when we meet again on next Sunday at 4:30. Thank you so much.
I think that answer whether we need to tell for the questions, I think.
Okay. Yeah.
Later, yeah.
Oh no, there are people who have answered. There are people who have answered. You may.
Can you, since you have that PowerPoint, will you just display that question 1 and 2? If required, we will answer that. Otherwise, if time permits that.
Let me check that, sir, because I think I'll have to download that PPT. I have not downloaded it. Maybe you would like to announce the answer. A lot of people have 1, 2, 3, or 4.
Okay, the first question. There are 4. Like we have a ventilation perfusion mismatch. We also have the diffusion impairment. Then we also have the third one is the intrapulmonary shunting and all of the above. The answer is D, all of the above for the first question. The second question, the answer is A. PaO2 by FiO2 less than 100 millimeter of mercury, non-ventilated, or PEEP more than 5 centimeter of water. Answer A. Thank you.
Thank you so much. Thank you so very much.
Thank you, Nitesh. Thank you so much. And I would like to extend my special thanks to Dr. Raju Parashar, Dr. Bela Sethi. They have been pioneers and they have been instrumental mentors in the journey of my career. And I thank Dr. Maiya, Dr. Savita, Ravindra, and Nitesh, you, to coordinate this beautiful session. I feel privileged to be able to share my experience today. Thank you, everybody.
Thank you so much.
Thanks a lot.
See you next Sunday at 4:30. Thank you so very much.